Hello, Jimmy. How are you today?
I'm doing good.
My name is Joe Andiko. I'm a nurse practitioner and I'm here to do your heart assessment today. Is that okay with you so I can do your heart assessment today?
That's okay.
All right. I will wash my hands. I already washed my hands, so I'm going to use a hand sanitizer. And as I do this, I'll ask Jimmy a little bit of history about his cardiac system. Jimmy, do you have high blood pressure?
No,
Have you been told by your doctor if you have any cardiac murmurs?
no,
Any pacemaker?
no,
Have you had any surgery, open heart surgery or any kind of surgery on your heart before?
no.
Okay, thank you very much. So to start off the cardiac assessment, I'll have to inspect the jugular vein, and to do that, I'll ask Jimmy to face the left side. Okay, and just by inspecting, I can see the pulsation right there. You can actually see it, and also you also look for any abnormal findings if there is any. I don't see any abnormal findings. And the next thing I need to do is to measure the jugular venous pressure. And to do that, I find the sternum and I measure that from the highest point of from the highest point where I can find. So this one is about 2 centimeters, and 2 centimeters is considered a normal finding. So I'll document that as a normal jugular venous pressure. Next, I'll ask you to turn around. Next, I'm going to do carotid assessment, carotid artery assessment, and for that, the first thing I have to do is basically inspection. So just look, look and see if there is any visible pulsations, which I can actually see. The carotid artery is just right around, just behind the sternocleidomastoid area, and so after the inspection, I don't see any abnormal findings. I can see the pulsations, and next I'm going to palpate, and you want to avoid massaging the carotid artery because you can lower the blood pressure. You also want to avoid palpating both sides of the carotid artery because you are likely to occlude blood flow to the brain, and you might cause some confusion with the patient. So so basically I'll start with I'm going to ask you to face the other side, and I'm going to palpate and listen to any kind of bruits or thrills, and then I also do the same thing on the other side. The normal finding here is that when you are doing the carotid artery, you want to, again, as I said earlier, you want to avoid occluding blood flow to the brain because this is likely to cause the patient is likely might even pass out. Okay. Next, after doing the palpation, you want to auscultate, and I'm going to use my stethoscope. You want to be able to auscultate using the bell and the diaphragm and the bell of the stethoscope. Okay, and you want the place where you are doing the auscultation to be quiet because you really want to be able to hear the sounds, the pulsations. And if there's a normal finding, you can listen for 30 seconds. Abnormal finds, you can listen for about 60 seconds. I say 30 seconds and 60 seconds. Okay, and then you want to listen with the bell of the stethoscope and also the diaphragm. So next I'll listen to using the diaphragm of the stethoscope for low pitched sounds. And as you listen, you are listening to the rhythm and of the pulsations and looking for any murmurs. Okay, and then you also do the same thing on the other side of the carotid artery. Okay, you also listen on the other side using the bell of the stethoscope and the diaphragm of the stethoscope. The palpation also should be done on the other side on both sides, but you have to do one side at a time. Okay, are you okay, Jimmy, so far?
I'm good.
Okay. Next, we are going to go down to the precordium, and the very first thing you need to do is just do an inspection of the patient's precordium. In a normal case, the patient is not supposed to have a vest on, so they're supposed to be laying down so you can be able to see clearly the chest. And you are looking for things like if a patient has any scars, or if they have a barrel chest, or if there's any air trapped in there, or fluid, or if the patient has a pacemaker. And you are supposed to look for things like those ones in a normal situation, and the patient should be lying down in a hospital bed. But in this case, the patient is sitting on a chair. But in a normal case, then to listen to this very carefully, the patient has to be laying down on a hospital bed at 45-degree angle. So for purposes of today, the patient is going to be sitting up like that, and we are going to listen. So to start with, you identify, basically after the inspection, the next thing you have to do is to identify the sternum. And from the sternum, you go about 2 notches down to the right intercostal muscle, and that by the sternal border, and that is where you find the aortic area. And the first thing you do is palpate the aortic valve, and you are listening, you are palpating firmly to feel for any abnormalities. And then next you go to the left intercostal space, the left second intercostal space by the sternal border, and that is where you find the pulmonic valve, and you also palpate that. So you go 1, 2, right around this area. And again, as I said, the patient will be laying down without a vest on, and you also palpate that. And then next, you move down to the third and fourth intercostal space by the sternal area, and you palpate that. Again, as I said, the patient will be laying down without a vest, and you palpate that. And finally, you go down to the fifth intercostal space, and that is by the mid-clavicular, and that's right around here. And that is why you find the apex of the heart. And that is actually the point of maximum impulse. So you palpate that. I can actually feel it. But if you can't feel it, then you can ask the patient to turn to the left recumbent position so that you can feel it very clearly. But in Jimmy's case right here, I can feel it even though he has a vest on. Okay. Once you're done with that, the next thing that you have to do is you auscultate. You auscultate using the diaphragm of the stethoscope, and also using the bell of the stethoscope. Again, you identify where the sternum is, and you go down to the second right intercostal space, and that is where you find the aortic area or the aortic valve, and you are going to listen with the diaphragm. And as you listen, you are listening to the amplitude and the rhythm of the heartbeat, and listening if there is any abnormal blood flow. And then next you go to the left side, the left second intercostal space by the sternal border, and that is where you find the pulmonic valve. And you listen also with the bell, with the diaphragm of your stethoscope. And then next you move to the third and fourth intercostal space, and by the left, the third and fourth left intercostal space, and this by sternal border, and that is where you find the ERBS point, ERBS. I gotta spell that with my little accent. Okay, so that is where you find it, and you listen to you auscultate that. And finally, you move down to the fifth intercostal space by the mid-clavicular line, and that is where you find the apex of the heart, and actually that's where you find the point of maximum impulse. Now, when you are listening to this, you listen to, if it's a normal, regular heartbeat, you listen for 30 seconds, and if it's irregular, then you listen for a whole 60 seconds. Okay, and that is around right here, the fifth intercostal space. And if you can't hear it, you ask the patient to lean forward so that you can listen to it very clearly. That kind of moves the heart closer to the skin. One of the things that you have to watch very carefully when you are doing, you're listening to the point of maximum impulse, if the patient has a large breast tissue, you're going to have to ask the patient to move it out of the place, or somebody who's muscular, or somebody who's obese, big guys. So you're going to have to move the breast tissue out of place so that you can listen very, very clearly, and you can understand, so that you can determine the flow, the rhythm, and the amplitude. Next, you go back again. You're going to sit back. Next, again, you go back and follow the same process. You listen to the second right intercostal space where you find the aortic valve, and you listen now using the bell of the stethoscope. The reason why you're using the bell of the stethoscope is you want to hear those low-pitched sounds that you cannot hear using the diaphragm of the stethoscope. You follow the same pattern. You start with the aortic valve, pulmonic valve, and then you go down to the Abs point, and then finally you listen at the point of maximum impulse, and that is the apex of the heart, which is on the fifth intercostal space by the mid-clavicular line. And that concludes the assessment of the precordium. And are you doing okay so far, Jim?
Yeah.
Great. Next, we are going to do the assessment of the peripheral vascular system. And really, you assess, again, in a normal situation, the patient will be laying down without a vest. And you just assess the abdominal area right by the umbilicus. And you are looking for any pulsations, any aortic aneurysm, any signs of any abnormal pulsations. And then you also look at, you inspect the patient's arms. I don't see any abnormal finds. You inspect the warmth, that their hands are warm to touch. And really, when you palpate the umbilicus, and you do a firm palpation on the just by the umbilicus, and to feel for any abnormalities. You might, when you're doing this, you might say things like abdominal distension, or if a patient has had an aneurysm, or if the patient has had an surgery, or things like those ones that you can see. But some of them might not even affect the cardiovascular system, but it's good to note those during your inspection and assessment process. And then next, we are going to do the radial pulse, and the radial pulse is just right here. And you do them both together so that you can compare for them both at the same time. I'm going to ask you to put your hand like this, yeah. And when you are checking for the radial pulse, you want to determine if it's symmetrical, it's equal on both arms, or if it's thready, or if the patient has any issues with the radial pulse. In this case, for Jim's case here, both of them are equal. And then next, you identify the brachial pulse, which is right here. You want to compare. Now, in some instances, you can do one at a time, and the brachial pulse is right around this area. And once you're done with the brachial pulse, and then now you can move to the lower extremities. And basically, the very first thing you have to do with the lower, may I have to, Jim, stretch your feet out, please? Now, again, as I said, in an ideal situation, the patient will be laying down in the bed, and with the feet stretched on the bed, where you are able to see the patient's feet. So the very first thing you have to do is just assess the patient's feet. Look for any bruising or any abnormalities. Look for the color of the skin. Look for the blood flow. If the patient has any edema, if the patient has any scars that are a sign of injury or anything of that sort. So in this case, I don't see any abnormal finding. The skin and tone of Jim's lower extremities, the feet and the legs is normal when compared with his race. So basically, it's normal. Next, then you have to. The next thing you have to do is just once you have done the inspection, you feel for the patient's the warmth, and you will inspect that using the back of your arms, because you don't want to use the palm of your hand because the skin is very thick. And then you just feel all the way down right from the knee all the way down to the metatarsals, and your feet are nice and warm, symmetrically. Okay. The next, what you're going to do is check for the popliteal pulse. The popliteal pulse is just behind the you want to bend your knee, behind the knee, and you're going to feel them right here. Compare them bilaterally. Okay. And once you're done with the popliteal pulse, you go down, and you want now to check the dorsalis pedis, which is basically on the first and second metatarsals where they meet by the ankle right up here, and this one right there. And you want to be able to listen to palpate them at the same time. Okay. Okay, they are strong. They are not bounding. They are strong. But one thing I'd like to say is, if you are listening to the dorsalis pedis pulse and you can't hear that, you can use a Doppler ultrasound, especially when you are auscultating. And then next, you want to the posterior tibials, which are found in the medial malleolus, right here on the back of the feet. And you can feel those. And in Jim's case, those both are symmetrical. The last thing you want to do is the capillary refill, and just check and see how long it takes for the blood to run, and just push on the capillaries. And in Jim's case, this takes about 3 seconds, which shows that he has normal capillary refill. And I don't see any other issues on Jim's feet. Sometimes if a client is diabetic, or you can see that on the client's feet. And sometimes if you see edema, that tells you that the client has some cardio issues. Now, one thing I forgot to do is the femoral artery inspection, and that is just right around here. And so the femoral artery for the patient is right there. So that's one thing I forgot to do, but you do the femoral artery inspection as well, which is right around here in the groin area, in the inner groin area. Okay? All right. Jim, are you doing okay so far?
I'm good.
All right. Okay, now that marks the end of today's assessment, and I'll see you next time. Thank you for coming.
Thank you.
Yeah.